A 34-year-old man is pulled from a burning house. He is severely distressed and struggling to breathe. In the ambulance, his presentation is alarming. He is deeply confused, gasping for air, and his heart rate is racing at 140 beats per minute. Given the heavy smoke inhalation, you suspect severe carbon monoxide poisoning. But when the medics place the pulse oximeter on his finger, the monitor displays a perfect, reassuring oxygen saturation, 99% on room air. A perfectly normal reading on a suffocating patient is a massive red flag. The data on the screen violently contradicts the physical reality in the bed. That 99% reading is a dangerous mathematical artifact baked into the optical engineering of the monitoring machine itself. This specific vulnerability catches even experienced clinicians off guard. In a recent UK Royal College of Anaesthetists primary exam, only 32% of candidates passed the question covering this exact discrepancy. The examiner's report noted a persistent issue. Candidates failed because they confused the underlying physics of standard pulse oximetry with the entirely different mechanics of co-oximetry. Standard pulse oximetry is an in vivo modality. It uses a non-invasive finger probe to provide a functional estimation of arterial oxygenation by measuring pulsatile blood flow through intact tissue. Co-oximetry is an in vitro modality. It requires extracting a physical blood sample to perform a discrete, absolute diagnostic measurement of multiple different hemoglobin species inside a machine. Despite the similar names, these two modalities utilize completely different physical architectures and mathematical assumptions. To understand why the pulse oximeter lies during a toxicological emergency, we must examine the physics of light absorption and why mastering the physical engineering of the co-oximeter is the only way to recognize its clinical necessity and structural limitations. A standard pulse oximeter operates by emitting exactly two specific wavelengths of light through your finger: red light at 660 nanometers and infrared light at 940 nanometers. This dual wavelength design relies on a rigid mathematical assumption. It calculates saturation by assuming that only two forms of hemoglobin exist in the blood: oxygenated and deoxygenated. Two wavelengths provide two equations to solve for two variables. This chart shows hemoglobin's near-infrared absorption spectra. Two curves show light absorption for oxygenated and deoxygenated hemoglobin. With carbon monoxide poisoning, a third curve appears: carboxyhemoglobin. Look at the 660 nanometer red wavelength mark. Here, the carboxyhemoglobin and oxyhemoglobin curves perfectly overlap. Because their absorption coefficients are identical at 660 nanometers, the pulse oximeter's photodetector cannot mathematically distinguish the light absorbed by the deadly carbon monoxide from the light absorbed by healthy oxygen. This two-wavelength architecture structurally blinds the machine to dyshemoglobins. It registers the carbon monoxide, applies its two-variable equation, and inevitably interprets fatal poisoning as perfectly oxygenated blood. Bypassing this blind spot requires the co-oximeter. This is a benchtop spectrophotometer that requires drawing an in vitro arterial blood sample directly from the patient, rather than relying on a non-invasive probe. The sample is drawn into a specific syringe coated with heparin. This prevents the blood from clotting prior to analysis. Once the sample is injected, the machine begins internal processing. It immediately heats the blood to a constant 37 degrees Celsius to stabilize the physical properties of the fluid. Next is the most critical mechanical step. A hemolyzer unit subjects the sample to high-frequency ultrasonic vibrations, violently rupturing the red blood cell membranes. This destruction solves a physics problem. Intact red blood cells act like tiny lenses, scattering light erratically, which invalidates the Beer-Lambert law's requirement for pure absorption. Destroying the cell walls creates a translucent, homogeneous fluid, allowing light beams to pass straight through without deflection. Mechanical hemolysis is the mandatory physical prerequisite that allows precise spectrophotometric equations to be applied accurately to a blood sample. During the light emission phase inside the co-oximeter, a polychromatic light source fires at a rapidly rotating filter wheel. This filter wheel splits the single light source into an array of highly specific wavelengths. Modern machines emit up to 17 separate beams that pass through the hemolyzed sample, reaching a highly sensitive array of sensing photodiodes. This broad optical spectrum allows the machine to detect the unique individual absorption signature of every hemoglobin species present in the fluid. It can simultaneously quantify total hemoglobin, oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin, methahemoglobin, and sulfahemoglobin. This generates a mathematical output known as true fractional saturation, or SaO2. This equation measures oxygenated hemoglobin against the total sum of all hemoglobin species. Contrast this directly with the pulse oximeter's functional saturation, or SpO2, which mathematically ignores dyshemoglobins and only measures oxygen against deoxygenated blood. By expanding the mathematical matrix from 2 wavelengths to 17, the co-oximeter transitions from a vulnerable estimator of oxygenation into an absolute diagnostic quantifier. Moving these modalities into the field exposes their respective clinical limitations. The pulse oximeter requires adequate peripheral pulsatile blood flow. It must detect the physical expansion of arteries to differentiate arterial blood from venous blood and tissue. In clinical states of severe hypotension, deep hypothermia, arrhythmias, or profound vasoconstriction, pulsatile flow drops. The pulse oximeter loses its signal and fails. The co-oximeter relies on a drawn sample analyzed inside a machine. It is completely insulated from the patient's in vivo perfusion status or cardiovascular collapse. But the co-oximeter carries a major temporal disadvantage. It is non-continuous. It provides a discrete, static snapshot of oxygenation at the exact moment the syringe filled with blood. The pulse oximeter provides continuous, real-time physiological trending, allowing clinicians to monitor dynamic changes with only a 10 to 20-second lag. The fundamental trade-off is between continuous vulnerability on the finger and discrete, absolute certainty from the lab. The pulse oximeter also suffers from external environmental vulnerabilities. Intense ambient light bleeding into the sensor or motion artifacts like patient shivering corrupt the readout. Additional clinical interferences skew pulse oximetry readings, including surgical diathermy and certain colors of nail varnish. While the co-oximeter is safe from the external clinical environment, its complexity introduces internal mechanical vulnerabilities. The primary risk is incomplete sample hemolysis. If the red blood cells do not completely rupture, light scatter will ruin the spectrophotometric calculation. Co-oximetry also demands a heavy operational burden. It requires strict, regular mechanical calibration. Furthermore, the blood sample must be processed immediately. Otherwise, cellular oxygen consumption inside the syringe will artificially lower the results. Neither machine is infallible. Pulse oximetry is compromised by the chaos of the patient's environment, while co-oximetry is compromised by internal mechanical upkeep. Revisiting the house fire patient reveals exactly why The divergence threshold occurs whenever the clinical presentation violently contradicts the monitor, especially in suspected toxin exposure, unexplained cyanosis, or hypoxia unresponsive to oxygen therapy. In these critical moments of divergence, the co-oximeter is the indispensable gold standard tool required to strip away the machine's assumptions and reveal the true physiological state.